You can use this.
Okay, good morning. Is this on? So good morning, welcome. This is the parallel session in pediatrics. We're going to be discussing pediatric and early adulthood pancreatic disease. We have three great, excellent speakers lined up today. I'm Andres Martinez. I'm from Vanderbilt University. I'm a pediatric gastroenterologist in Nashville. So each speaker is going to have 15 minutes for their talk, and then I'll ask you to hold your questions. We'll have 15 minutes at the end for Q&A. Okay, so our first speaker, Dr. Ali Aouk, is a professor of pediatric gastroenterology, also endowed chair in gastroenterology at the University of Iowa. She's also been one of the lead principal investigators for INSPIRE, our study group, which has been so successful, so productive for over 10 years. The topic of her talk today is clinical trials that are needed in children. So welcome, Dr. Aouk.
Thank you for the kind introduction, and it's great to be here in Pancreas Fest. So I have no disclosures, and so I'm a division director of for about 6 years. And when I took the division directorship, I changed the division's name, and I called it Pediatric Gastroenterology, Hepatology, Pancreatology, and Nutrition. And the reason for that was that I just wanted, as gastroenterologists, to own this organ. Because I think as gastroenterologists, for a long time, we haven't. So far, I'm the only division director that has done that, and I think that's going to stop with me, but that's just another story. Okay. All right, but that's okay. So it just, you know, the history of pediatric pancreatitis just goes not that far. I just wanted to give you a little background about that. And if you look into the PubMed and then just how far we go, it doesn't go that far, right? I mean, you know, just look back and, you know, 1940s to 1990s, there's just almost nothing published about pediatric pancreatitis. It's just almost like a flat line. And there's just something between 1990s and maybe early 2010, there's just some few papers. And then it looks like it's just taken off a little bit. And then there's just a huge bump. And don't mind that little drop. I mean, that's because the 2023 is not over yet. So there's definitely an increase, and there are reasons for that, I think. That's just at least my impression. So I'm just gonna review what happened, and I think you all in this audience contributed to this understanding and to that bump. And then the question is, where do we go from here? Like, what do we do to take this field forward? And there's just a lot to be done. And I can just stop here. That is just, we have a lot to do. But then, you give me 15 minutes to talk about it, and I'll do my best. So what I will just say that between 1990s and 2011, as pediatric gastroenterologists, we didn't think pancreas just belonged in the GI tract, okay? So let's just admit it, we didn't. And if you look into the literature, there are case studies, case reports, pancreatic complications of systemic illness, trauma, tumors, TPIAT, ERCP, diabetes, a few gene mutations. I think there were reports from the European cohorts, one quality of life study, a few increased incidents about awareness, perhaps increased awareness or incidents or awareness, but those were coming from surgeons, endoscopists, trauma people, not from gastroenterologists. I think we just thought that, this is not an organ that really belonged to gastroenterology. So in 2009, I think that's because of my basic science interest in cystic fibrosis and pancreatic disease, I attended this conference, and I met with Mark Lowe, and then we just decided, okay, there's probably something to do about the pancreas more than we think. And then that's how, the Inspire idea was born. And of course, this whole community, I think, just formed. And then it's so gratifying that this field has grown. And I'm not saying that this is all due to Inspire. I think it was bound to happen. And if you think about it, even the definitions have not existed until 2012. I mean, this is a very, very new field. And then this is the first time we just all agree that we will have a pediatric definitions of pediatric pancreatitis, ARP, and CP. So that goes like a little over 10 years. And, there are Inspire papers, and then NASPGHAN just took interest, and, those were position papers. But if you think about it, those are really very nascent efforts, and there are just so much more to be done. And I'm not going to really talk about all the efforts from the people in this room that has contributed to the understanding, but we have to do more. And I think that is the reason for this session and why you invited me to give this talk. And I can give you my ideas, but there's a lot to be done. And what we have to do, I think, is that we have to listen to our patients. I mean, patients are very, they're there, they're our partners, but what they want us to do is like, how can you help us to improve our lives? And you all have heard about National Pancreas Foundation, Mission Cure, most of the patient report. So what they're telling us, number one, is that there are no treatments. And on the other hand, there's a high burden of symptoms with a great impact on life. So what can we do to bridge that gap? And so I think that is now published. And then there's an Inspire patient parent survey also talking about, okay, there's a lot of pain, there are a lot of attacks, but there's a gap. So we have to come up with treatments. If so, what? What should be the next step? What should we do? How can we help? So, and I'm just gonna tell you by saying that, okay, where are we now? I told you already where have we been? Where are we now? And hopefully what we need to do to bridge that gap, and how can we get there, and what should be the next few steps. I think that probably can keep us busy for the next 10 some years, but we have to start somewhere. So where are we now in terms of clinical trials and what is being done? And I think this is not a strange concept to you, and I probably can just stop this right now because there are only a few trials, and there are many reasons for that. But if you put this pediatric pancreatitis, you come up with only very few trials. And this is if I eliminate diabetes, if I eliminate cystic fibrosis, pancreatic enzyme therapy, and I only look for pediatric pancreatitis, I find only a few. And I will review them for you, and then you can just see where we are and what should be the next step. So those are mainly pain, coupling acute pancreatitis, and coupling acute recurrent and chronic pancreatitis and PEP prevention. So let's just review where we are. So where we are right now, and hopefully where we should be. One is just really came up from the Inspire. I would just say that it took a while. I mean, all clinical trials, as we're all finding out, take a lot of work to get it off the ground. But this is, I mean, we're thankful for Dr. Palermo to really partner with us. This started in pediatrics and now also, you know, spread into the adults. And they've already shown in adults that cognitive behavioral therapy is helpful for adults with chronic pain. But we have a randomized controlled trial going on with education arm and the CBT arm. The beauty of it is that it is applicable through the web. And we have some challenges for recruitment because we don't have a lot of kids with chronic pain, which is good for us. But there were some challenges, but this study is nearing completion right now, and it was funded. So that's just one of them, but this is gonna end pretty soon. The other one that I found was from Boston Children's. This is looking into the impact of pain. So opioid versus non-opioid. Can we reduce the amount of opioids in patients admitted for acute pancreatitis? So this has started. I think it's going to be ending pretty soon. We will see. There are no publication that came out of the result because the study is still ongoing. So pain and acute pancreatitis and their outcome is what happens to them. Are they getting less opioids? Are they getting better over time? Time to opioid usage. The third one, so I have one more to go. So the third one is from the Europe, and it's really not focusing on pediatrics. So this is just looking into the impact of the fat, the amount of fat in the diet, and whether that has any impact on the recurrence of the attacks. They will either give normal amount of fat or reduced amount of fat, and whether that just has anything to do with the recurrence. 14 or so, 14 and above. And they also started enrolling. And this is the fourth one is Dr. Vitale is in the audience. I think this study is also ongoing and looking into the impact of two NSAIDs. One is rectal, the other one is IV in post-ERCP pancreatitis, and just see which one is efficacious. So those are the ones that I found in the clinical trials database. And if I missed your study, you're in the audience, I apologize, but this is what's going on at the moment in terms of pancreatitis world. And those are my ideas. I'm gonna just divide them in three different categories: acute pancreatitis, acute recurrent pancreatitis, and chronic pancreatitis. That what we should focus, because you have given me the idea of like what trials are needed. We need a lot of trials, but we also have a lot of gaps. So if I'm doing the acute pancreatitis clinical trial, I think I would focus on probably preventing the sickness. Like, how can we prevent the sickest patients and most burden from the happening? So this is, I would probably focus on preventing and treating local and systemic complications. And this is not universal to us. I think the adults are also dealing with the same problem, like fluid type, what kind of fluid, the volume, the rate. So this is ongoing in the adult world too. So it's not like, you know, this is our problem only. I think we know how to treat mild acute pancreatitis, but can we prevent and treat and get them out of the hospital with less morbidity and mortality possible? Nutrition, timing, and composition for the sickest ones. I think necrotizing pancreatitis is a problem. We don't see it a lot, but certainly L-asparaginase-induced pancreatitis and their complications. I mean, many of us deal with this. is a problem. If we have a way to better treat and prevent that, I think that's something that I would focus on. Pain management, I think that's another area. And then which ones are going to progress to acute recurrent pancreatitis? I mean, many of them don't, but which ones are going to focus? And something like, is going to require a database and prospective database. I think that's also an area of research. As many of you know in the audience, that timing of recruitment for acute pancreatitis is critical, because a lot of times for those of us remaining working in the tertiary care center, by the time we see those patients, I mean, the cat is out of the bag. I mean, the cytokine storm has started. Patients are already sick. Perhaps they peaked. So we have to know when we deal with those patients. So I think we have to recruit at the earliest time possible, and ideally at the local hospital and ER. And that's a challenge sometimes. So we have to have partnership with the ER or other local hospitals. And we have to choose the outcomes very carefully so that we know what we're looking for. So I think this is my idea of acute pancreatitis. You can add your own. Acute recurrent pancreatitis, I think this is something that I would focus on going forward. And there are already some efforts within Inspire to work on that. And our patients are telling us already, they don't like attacks. Nobody likes them, because they're in the emergency room, in the hospital, and that's very disrupting. And perhaps they're adding to patients, progress to chronic pancreatitis. We do not know that. We think it could be the case. So I would try to stop the attacks from happening if I could. And that is the reason behind the PAUSE trial. I mean, this is a signal that we would like to pursue. And CFTR modulators, if we could. I mean, this is something that we would like to pursue. And if there's a way to stop the progression to chronic pancreatitis, this is definitely something that Inspire would be interested in. And I think all the others are similar to acute pancreatitis. I mean, when they're sick with an illness. Trials needed in chronic pancreatitis if the scar has already set in. I mean, we would like to prevent further scar, further burden in the patient. And there's still a lot that we don't understand in exocrine pancreatic insufficiency or progression into exocrine pancreatic insufficiency or diabetes. I think that's the focus of the Inspire, and we would like to answer those questions. And osteoporosis, I think there's a paper coming out about that. Are there things that we can do, make an impact in the pediatric age group, because those patients are not going to stay pediatric age group forever. And then we don't know how to treat exocrine pancreatic insufficiency or diagnose, or the same for diabetes. And finally, the treatment of pain and quality of life if the patients are in that stage. And again, for ARP and CP, it may be different based on the underlying risk factor. I mean, I may be treating differently a PRSS1 patient versus a CFTR mutation patient. So those are my ideas. I think, of course, there are challenges, and some of you who would listen to my talk at the APA last year, you have seen this. And I think this is something that we will have to deal with in pediatric age group. And I think also for the adults. I mean, we are dealing with a rare disorder. Sample size is a problem. I think we have to choose our sample size, our treatment, tailor for the patient very carefully. So if I treat a patient with a CFTR mutation with a pancreatic enzyme, how am I going to select that patient later on for a CFTR modulator? There are only few multi-center trials. There is lack of industry interest. And I think endpoints and outcomes are very important. And this is, I think, something that I appreciate that this is Mission Care has taken that on, because we're not going to be able to measure what we are treating if we don't have well-established endpoints and outcomes. And there's a bias that the pediatric cohort is not a good target. There are a lot of issues. Actually, this is a good time to intervene. Funding is always a problem. It's been a problem. I think for pediatrics is even more of a problem. So we are dealing with less than 2 decades of life versus adults is more than that. But then the funding is about 10% of what the adult cohort is receiving in pediatric research. Youth represent about 20% of the US population, but they don't have a voice. We have to be their voice. I think it's very important that, you know, we all advocate for the youth because they don't have a voice, they don't vote. So, I mean, this is something that needs to change in the future. And pediatric patients that have pancreatic disorders don't outgrow their problem. Very much so is like cardiovascular problem, obesity, mental health, they don't outgrow their problem. They're gonna take that into the adulthood. So I think this is something that needs to be very well explained to the stakeholders that this is something that is best addressed when they're pediatric injuries.
Yes, we have a minute.
Yeah. So I think in summary is we don't have many pediatric clinical trials. So, and there are many reasons for that. I think people in this audience is going to take this field forward. The challenges are obvious. We have small sample size. We need to work on endpoints and outcomes. We're working on the national history. Funding is a problem. And I think going forward, it's very important that we have advocacy and funding support. And that's it.
You want to go at the end, at the very end, the questions. No, it's you can sit right here. You can go and sit over here, and we'll take questions after all our talks. So our next speaker, Dr. Tom Lin, is a professor of pediatric gastroenterology, also trained in advanced endoscopy. He's currently at the Rady Children's Hospital, which is affiliated with the University of California, San Diego. And he's going to talk to us about endoscopic management and pediatric pancreatitis.
Thanks, Andreas. I want to thank you for to speak at Pancreas Fest. It's always a pleasure to be here, whether it be attendance or providing a so no disclosures, a few things on objectives. I thought I'd start off with kind of stating the current state of endoscopy management for pediatric pancreatitis and highlighting some of the challenges that we're currently confronted with. I'll provide a kind of a global review of diagnostic and therapeutic endoscopic management for pediatric pancreatitis, and then laying out some groundwork for what the future is for endoscopy in pediatric pancreatitis. So I thought it'd be representative to start off with a case first. And so this is a patient I just recently saw. So a 14-year-old male with chronic pancreatitis who's actually visiting from out of state to see his father over in Southern California. And so he already had established genetic identifications for risk factors, distinct one as well as CTRC. Already had several ERCPs performed locally back at home that identified that he had complete pancreatitis, already had endotherapy related to a minor papilla sphincterotomy. And also had a phenotype of having intraductal stones that were extracted, but despite these endotherapies from the ERCP, he had limited clinical benefits. He wasn't necessarily debilitated as it relates to his disease, but there were issues about the trend that he was going forward with. So he came to Southern California not having any particular symptoms, and lo and behold, Murphy's Law always happens when you least suspect it in regards to when things flare as it relates to pediatric pancreatitis. So as I mentioned, he was still visiting out of state. I wasn't aware of him until after a week into his hospitalization. So he already had a repeat MRCP at the beginning of the course of his hospitalization. And the radiologist kind of described him having a dilated pancreatic duct, having acute pancreatitis as well, but he was having this slow, low-grade persistent pancreatitis and not necessarily turning a corner in regards to his recovery. So again, it was a week until I got involved in his care. So despite the degree that he didn't necessarily have any obvious endotherapy that was going to be beneficial for impeding the ERCP when he was in Southern California, I think it's always helpful to look at the MRCP myself or review it with my friend and radiologist. And so despite there not being any type of abnormalities identified other than the pancreatic duct being dilated and acute pancreatitis, clearly when I reviewed the MRCP, he had these intraductal stones. So the bigger question is this the source for his acute flare, or is it his more underlying disease process of chronic pancreatitis? So again, because of prolonged hospitalization, I went forward with his ERCP, and despite the fact that he hadn't had any major benefit from having an ERCP before. So at the time of his ERCP, and believe it or not, this is actually the same patient, and his stones look a little bit different at the time of the ERCP. So he had very large stones in his pancreatic duct, and he already had a sphincterotomy. So I extracted those stones, and he was actually returned porter rather quickly, and he's discharged within 24 hours. So as it relates to the current challenges, as Leo was kind of mentioning in this kind of prior to the endoscopic challenges that we have, the disease as well as endoscopic interventions for pediatric pancreatitis are much less common in children compared to our adult colleagues and adult patients for pancreatitis. And so this leads to issues of having problems with being able to study it effectively, and maybe even leading to some national guidelines that provide some guidance about when is it appropriate to perform various either diagnostic or therapeutic endotherapy. More on top of that, there continues to be an under-recognition even amongst pediatric gastroenterologists for the diagnostic and therapeutic utility of these endoscopic therapies. And so there needs to be some improvement in regards to that. As I suggested on the case I presented, radiographic imaging limitations do exist. I think there's a need to focus on improved training of pediatric radiologists who may not be so familiar with some of the findings that can occur in chronic pancreatitis patients, but also maybe some of the limitations in MRCP that I'll kind of highlight in a second. And then lastly, there's limited access to pediatric interventional endoscopy, specifically pediatric gastroenterologists, because there are some training limitations in regards to pediatric gastroenterologists. Despite their desire to pursue such training, those opportunities are very limited. So that's also another obstacle to overcome. So starting with endoscopic endotherapy or endoscopic diagnostic interventions for pediatric pancreatitis. So as we know, EGD can be a diagnostic modality on a rare, very rare occasion. Chronic Crohn's disease as well as celiac disease can be associated with acute pancreatitis as well as recurrent pancreatitis. And then we know about endoscopic pancreatic function testing as a diagnostic modality for pancreatitis or chronic pancreatitis. For ERCP, from the diagnostic standpoint, very few authorities meet, but there can be diagnostic indications even still for performing an ERCP in the context of pancreatic trauma. This allows perhaps the surgeon be able to plan any type of surgical intervention in that particular context. And then, as I suggested, there are some limitations for MRCP for identifying congenital punctal anomalies, where ERCP can be diagnostic for those type of issues. Endoscopic ultrasound will kind of touch upon that in regards to acute recurrent and chronic pancreatitis and the utility for that. And then, as we've heard over the last 2 days, the U.S. can be much more sensitive than other imaging modalities for diagnosis of cholelithiasis, more specifically microlithiasis. So our adult colleagues have had these classification systems for identifying or supporting a diagnosis of chronic pancreatitis. And so the challenge from that standpoint, both for ERCP as it relates to the Cambridge classification, which is rather old, and then EUS for Rosemont classification, they are adult criteria and they have not been validated in pediatrics. That being said, within the pediatric realm, we tend to apply some of these criteria to our pediatric patients, but likely not completely applicable because of the underlying etiologies can be very different from our adult patients. This was shown yesterday at one of the talks related to one of the position papers for the utility of EUS as well as the ERCP for chronic pancreatitis. And so I think it was a very good step in the right direction for publishing this position paper to provide some level of guidance. But as the paper themselves kind of stated, this review exercise highlights the paucity of research and literature available in pediatric EUS and ERCP, and thus the recommendations that they did provide were based on low to very low quality of evidence and primarily representative of consensus expert opinion. So there's much more work that needs to be done from that standpoint. This is a table from that same paper, and this really shows from the Cambridge criteria that classification that does exist. A lot of things are not applicable, or at least we just don't know how applicable they are in pediatrics. So I wanted to put a little bit more focus on ERCP and EUS. And so, as we know, ERCP in children, there can be existing limitations for MRCP as it relates to the sensitivity for detecting various abnormalities. And so, one of the couple of studies out there identifying reliably pancreatic stones can be one of the limitations, and then identifying reliably congenital ductal anomalies can be also one of the limitations. So, because of this, the gold standard continue for ductal imaging continues to be ERCP. As I suggested before, it is predominantly reserved for therapeutic interventions, though there can be diagnostic indications occasionally. And I tend to emphasize this, that though ERCP can be technically successful in regards to what you intend to do and what you need to do, it may not necessarily help alleviate the clinical symptoms for the patients. So for ERCP specifically, it comes down to being a kind of a glorified plumber. And so there's various things that we can do to alleviate ductal obstruction and the process of chronic pancreatitis. And so one of the examples classically of this is pancreas diseasum, though there's continued controversy of whether this is a true disease entity. And so a couple of papers, both from Inspire as well as my time over at Cincinnati, came out to help support the idea that pancreas diseasum and the subset of patients does exist and can actually be helpful in regards to going forward with endotherapy, but there's additional research that needs to support this idea. Although colleagues have also attempted to have a better approach to this on whether or not having endotherapy for pancreas diseasum is legitimate and whether it may lead to any type of benefits. So the SHARP trial began their recruitment in 2018. And their end recruitment is going to be at 2025. And so I understand that there's been difficulties in regards to recruitment for this particular trial. And again, it's an adult-based trial for pancreas diseasum. And so you can imagine that if they're having difficulty recruiting enough patients on the adult side, having such a similar study for this or other type of endotherapies for pediatrics would be equally, if not more challenging. So a couple of cases that demonstrate ERCP and maybe some of the limitations I kind of mentioned to you here. So 17-year-old female with cerebral palsy, enteral feeding tube dependence, history of acute recurrent pancreatitis, also had a prolonged hospitalization as well. So because of that prolonged hospitalization, despite maybe not having any clear indication for performing an ERCP, went forward with an ERCP. And so at that point in time, I typically, even if there's a suspicion for pancreas diseasum, I'll start with accumulating in the major papilla, see what kind of ventral pancreatic duct I get, and you can see there's a truncated blind ending ventral pancreatic duct. And so with that, it's either a stricture or we're having complete pancreas diseasum. So accessing the minor papilla proves that the patient has complete pancreas diseasum. There's some mild dilatation of the main pancreatic duct along with some side branches. Another case here is a 4-year-old that was previously healthy and had a recurrence of pancreatitis after having a nipple episode about 3 to 4 weeks beforehand. Also had some elevated LFTs, but also had a corroborating elevated lipase. And so the MRCP can be local, not hospitalized at the time, identified cholelithiasis and packaged her as having gallstone pancreatitis. So it kind of occurred to me, well, why would a 4-year-old have gallstone pancreatitis? And so when I reviewed the MRCP, pretty clear to me that this is a long common channel with a large fluid defect in that large common channel. And so went forward with the ERCP, nothing unusual with the major papilla, but very similar findings on the contrast injection of that large fluid defect within the large common channel, had the sphincterosity, and then balloon extraction of the obstructing sludge material from there, and the patient did very well from that standpoint. You can see after the extraction, the dilated long common channel was very much decompressed. So moving on to endoscopic ultrasound, Dr. Gugan presented a very detailed talk on this yesterday, so I'm not going to go into detail very much, maybe highlight some key points. One thing is that one of the questions often that comes about is how small a child can you actually perform an endoscopic ultrasound? So with standard adult equipment, referring back to that position paper that I showed before, within JPGN, it can be safely, using adult EUS equipment can be safely performed in children who are greater than 15 kilos. And so that being the case, still there's some level of caution passing that large of a scope in that small of a child, but it can be it has shown to be feasible and safe to perform, and that's down to that. So from a diagnostic standpoint, I mentioned before about polydopal biases, has a greater sensitivity above MRCP as well as other imaging modalities for identifying polydopal biases as well as microlithiasis. Chronic pancreatitis, we touched upon that too as well, and so those limitations of the Rosemont criteria that exist and the applicability in pediatrics. And then from a diagnostic standpoint, allow FNA as well as FNB for getting tissue sampling for various disease processes. So for chronic pancreatitis, on the adult side, which trickles down to our pediatric, within our pediatric realm, there clearly is no agreement on the appropriate reference standard for chronic pancreatitis. And so most especially for early and minimal change chronic pancreatitis, and we heard of this on a few talks yesterday as well. And so more than likely utilizing a stoppable ultrasound for chronic pancreatitis with the current criteria that we have, likely is leading to overdiagnosis of early chronic pancreatitis because we still have that not defined. This was also mentioned yesterday as well, that there for EUS and chronic pancreatitis, there's been observed variability. And as I suggested, the validity of Rosemont classification in pediatrics is an ongoing issue.
We have one.
One of the more recent studies that's suggested the utility of endoscopic ultrasound for acute recurrent pancreatitis came out a few years ago. Not a huge number in regards to the cohort that they studied, but they demonstrated that, as I suggested, the US is safe and can be technically successful in kids. And from that small cohort, they actually were able to identify, they utilized Cambridge criteria rather than Rosemont criteria, but they identified chronic pancreatitis in 31% of the patients. So likely some level of utility for acute recurrent pancreatitis that we can children. From a therapeutic standpoint, right everyone to fail the ERCP, drainage of pancreatic fluid collection is one of the greater utilities for therapeutic application of endoscopic ultrasound. So the question is when, how, and the efficacy and safety of these fluid collections. And so for asymptomatic, even despite having large pseudocyst or walled-off necrosis, observation is the key. If the patient has minimal to no symptoms. And so the question is, when do you actually intervene from an EUS drainage standpoint? So if they have significant symptoms, or in the general sense of an intolerance of animal feeds, those would be primary indications for going forward with EUS drainage. So if EUS drainage is required, transgastric or transduodenal approach would be the appropriate window to accomplish. There's low complication rates from this standpoint. And then if there's from a walled-off standpoint, if there's a necrosectomy that's needed, endoscopic approach is also recommended rather than a surgical approach or radiologic approach. So key points from my talk, hopefully I was able to demonstrate that there is a diagnostic and therapeutic utility for endoscopic care in pediatric pancreatitis. However, much is based on low quality evidence and primarily expert opinion with a significant extrapolation from our adult colleagues in their practice. There's a need for robust research in pediatric pancreatitis endoscopic care that's tailored to children who could be causing specifically possess etiologies that differ from adult patients. And there's a need that exists for improvements in awareness and training of pediatric pancreatitis and the associated abnormalities that can be found on radiologic imaging. So my last slide for the future, there's already existing two multi-institutional collaborations to pool patients because of low numbers. So Inspire 2 is moving forward with that, and then Dave Trundle over in Dallas has initiated in the past pediatric ERCP database initiative, and we're going to reinitiate that study group again through the ERCP SIG. Randomized controlled trials are optimal for studying endoscopic therapy for pediatric pancreatitis, as I suggested, those are significant obstacles to overcome. And then lastly, improving our collaboration with our adult colleagues to be able to better follow these patients over time, to have a better understanding on whether or not our engine therapies that we're performing in kids are durable and whether we're doing the appropriate thing and perhaps But if it's not durable, should the patient undergo surgery earlier rather than later? Thank you.
Thank you, Dr. So, our last speaker, Dr. Andrew Trout, is a radiologist at Cincinnati Children's Hospital. His research focuses on in pediatric pancreatic disease. The topic, the title of his talk is "Which imaging do you need for your patient with pancreatic disease?" Dr. Trout.
Good morning, everybody. A lot of you in this room know me. And so my talk today is not really going to be an exhaustive review of imaging in pediatrics, because I think most of you in this room are relatively comfortable with the use of imaging in this space, but I'm going to try and be a little bit provocative, both in terms of clinical guidelines that exist in this space and opportunities where we can move forward as it relates to research. So when we think about imaging in general and what sort of imaging you need, it depends on your goal, right? Obviously, the type of imaging that you're going to do in clinical space is a bit different than what you're going to do in the research space, but there is a lot of overlap, particularly when we're sort of confined to doing a lot of observational and retrospective type research. In general terms, my broad message for clinical use of imaging: do it. And by it, I mean imaging, and do it right, okay? And the do it right is an important piece. And we're meeting over noon today to talk through some of this. And there's a lot of ongoing effort just in general in this space. But the point is that when you are acquiring image for clinical reasons, we need to be doing it right instead of just doing it blindly, following policy or following practice or otherwise. And my broad message as it relates to research is that this is a huge, wide open frontier. Imaging presents massive opportunity for us to move the field forward in all of the areas that people are interested in looking at. And it provides one of the only non-invasive ways to take care of our patients. So let's talk a little bit about clinical tools. So ultrasound, everyone is very aware of ultrasound and its use. It's considered our first line imaging modality in a child with pancreatitis, which makes very little sense. There are multiple studies out there that have shown that ultrasound has has low to moderate sensitivity for the diagnosis of acute pancreatitis. So that sensitivity is somewhere between 27 to 75%, depending on the paper. And so the argument could be made, why are we using ultrasound in this space? Now, there are good reasons to use ultrasound, but I would argue not for making a diagnosis of acute pancreatitis. And so I think we need to all come together and agree or be clear on why we are using ultrasound as our first line imaging modality. And so I'd encourage you to show up at noon today and then to continue this conversation after that. As it relates to CT, everybody's well aware of the role of CT. CT with contrast in bright pink letters there, great for quick assessments for everything you'd want to know for acute pancreatitis, and certainly good in the acutely ill patient. Please, 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 please do not do a CT without IV contrast. I see far too many patients referred to our institution who have had a CT without IV contrast, and those exams are basically useless. So do not do it, please. And I'll come back to this case in a moment here. This was a patient that recently presented to us with a quote unquote history of acute pancreatitis. And there's not much we can tell here other than the head of the pancreas and whatnot is a bit full there. And there might be some sort of a fluid collection there, but it's not clear at all what's going on in this patient. The other point I want to make about CT is the best metric for calcifications. And this is true in the clinical space, and this is true in the research space. And I want to show you one case. So this is a single patient, all 3 images obtained within a period of 2 months. On the image there on the left, pretty clearly this patient has calcifications. On the image in the middle, the ultrasound, the pancreas is certainly heterogeneous. There's some echogenic foci, but none of those are distinctively shadowing to be clear that there's calcification. And there's that MRI on the right, and those calcifications are invisible. And so the point that I would make to you is we should not be qualifying or calling the presence or absence of calcifications on any modality other than CT. So when we're databasing patients and there's no mention of calcification in an MRI report, that doesn't mean calcifications are not present. And so I think we need to be clear about that as we are reporting imaging findings on our patients going forward. MRI, I think everybody in this room is well aware, has the highest sensitivity and specificity for acute pancreatitis, but there are very real logistical hurdles as it relates to exam duration and cost. We are increasingly doing MRI in our emergency department. We're down to a protocol that takes less than 5 minutes for the child that presents with right lower quadrant pain. And we are making effective diagnoses of appendicitis, ovarian torsion, and we have had multiple children with acute pancreatitis presenting with right lower quadrant pain that we have identified on a 3-sequence MRI protocol. I would tell you, you can diagnose acute pancreatitis with one MRI sequence, that T2 fat saturated sequence, and that can be acquired in less than a minute and a half. So these are the frontiers that we need to be exploring, particularly as we want to optimize diagnosis of our patients. MRI also provides the most information about fluid collections in pancreas health. CT, rapid, quick, but it is well known to underestimate the complexity of fluid collections, which is relevant when our colleagues in the endoscopy space are considering potential interventions on these fluid collections. So I take you back to that child that presented with a non-contrast CT scan, not at all clear what's going on here, other than there's some fullness here sort of in the region of the head of the pancreas, and there's what looks potentially like a fluid collection, not clear where that's coming from. Patient went on to have an MRI. Here again, a single sequence of fat saturated T2 weighted sequence, pretty clear that there is a fluid collection there between the pylorus and the pancreas. There is a lot of edema around the abdomen, marked gastric wall edema, but very little to no pancreatic edema. So it's not clear that this, in fact, is a pancreas-related problem at all, other than it happens to be in the immediate vicinity of the pancreas. The other piece that's important to recognize about MRI is it is the only modality that allows us to do non-invasive Cambridge scoring. Now, we've had a lot of conversation at this meeting about the difficulties with Cambridge scoring, but it still remains one of our accepted imaging criteria for diagnosis of CP, and MRI is the only modality, a non-invasive modality that allows us to do Cambridge scoring. And so we shouldn't be trying to do it with CT or ultrasound or anything else. Couple of other quick points. I talked about the importance of contrast for a CT. Please, please, please do not do your CTs without IV contrast. It is also useful in MRI for necrosis and for looking at collections in vessels, and it's certainly extremely important in tumors. Brief word about secretin, not to dwell on this too much, but there are data out there that have shown that it improves duct visualization, including the relationship of ducts to fluid collections or masses. And then we and others are working on assessing secretory response with secretin. So there is some utility to using this agent when you're doing MRIs of your patients. So let's move on to research a little bit. Now, there's a massive amount of research going on in the imaging space. We heard about some of this yesterday, so I certainly can't cover all of this, but I want to cover two main topics. One of these is pancreas volume, because this gets at the question of atrophy, and the other is quantitative imaging, or so-called pancreas radiomics. The important thing to recognize about both of these tools and both of these frontiers for the future is that they rely on high quality, usually three-dimensional images, whether that's CT, MRI, and PET. And you all know we're not doing a whole lot of this in pediatrics, except when our patients are really sick. And so I would make an argument that if we're going to move the field forward, we need to be doing more imaging with CT and MRI in situations where we can leverage that to explore caring better for our patients. So let's talk a little bit about pancreas volume. So the adult group in the Minimap study and other studies have shown that pancreas volume is lower in patients with confirmed chronic pancreatitis. That's from one of their studies. I would tell you that pancreas volume can be markedly decreased after even a single attack of acute pancreatitis. So here's a patient that presented with a severe attack of acute pancreatitis. We see areas of necrosis, we see acute fluid collections, and when that patient had resolved, that pancreas is very small, very atrophic. And this is not a feature that we are really accounting for necessarily in how we are taking care of these patients in the current era. I had a poster up yesterday that some of you came to talk to me about that looked at this as well, demonstrating this phenomenon in multiple other patients with both acute and acute recurrent pancreatitis. So this is not just a finding of quote unquote chronic pancreatitis, whatever that is, again, thinking back to what we talked about yesterday, but it is a finding that we're seeing even after one or just a couple of attacks of pancreatitis in these patients. And some people might say, who cares? Well, I'll tell you who cares and why we should care. What does volume loss reflect? Well, if you look at the adult literature, Vikesh's group came out and said, oh, volume loss not related to fibrosis, at least in their series. But Michelle Saad, who's with us at Cincinnati Children's, has data coming out that shows that volume is associated with fibrosis in patients who are undergoing TPIT. So volume appears to be linked to fibrosis. This is a study that came out of India where they followed up patients after attacks of acute pancreatitis or acute recurrent pancreatitis. And they demonstrated that these patients had some residual exocrine insufficiency in a subset of patients, prediabetes in another subset of patients, and those aligned with residual changes on endoscopic ultrasound, some of which included loss of volume of the parenchyma. In addition, there is a large body of literature linking parenchymal volume, a simple metric, to things like diabetes and exocrine function. So this study on the top showed links to both exocrine and endocrine function. Same with our study there in the middle, a prior study by Michelle Saad, and then that study that came out of India. There's also a significant volume of literature that suggests that pancreas volumes are lower in patients with diabetes, both type 2 and type 1, and that pancreas volume is associated with the duration of diabetes. So these decrements in volume that we are seeing on imaging can be linked to the outcomes that we are interested in. And yet we're not really paying all that much attention to it. I want to then talk very briefly about quantitative imaging and pancreas radiomics. So this is to some degree where this space is going, and pancreas volume is one of the many radiomic features or quantitative features that we can get at. Quantitative imaging is important. As many of you know, we conducted a study under the auspices of Inspire in the past that demonstrated some of the difficulties with inter-observer agreement among radiologists. A lot of the criteria that we currently use are subjective, and there's a lot of variability between radiologists. There was a poster yesterday out of Hopkins that showed the same thing as it related to something as simple as the diagnosis of acute pancreatitis. So we really do need to move to these more objective metrics, particularly as we're going to try to advance the field forward. So things like volume can get us to that, but there are other ways that we can characterize or quantify the imaging appearance of the pancreas. So the adults are doing this with their mini-map study, which Dr. Turkus talked about yesterday, where they're doing multiple different forms of image contrast. We are doing something similar under R01, our R01 in children, linking some of these quantitative MR imaging features to outcomes of interest. The other big area is what's so-called radiomics. And what radiomics is, and this is a graphical representation of that from Radiographics, which is one of our journals in radiology. Essentially, what you do is you do a detailed segmentation of a lesion or an organ of interest, and then you extract multiple image features at the pixel level. Okay, and these pixel level features can be everything from very coarse features like volume, like shape, like surface contour, et cetera, to things as finite and very small as how many dark gray pixels do you have in a row, or how much heterogeneity do you have among your pixels. And this is exciting. Vikesh mentioned this at the NIH session before, texture analysis of the pancreas as an indicator of fibrosis. And folks are getting some traction in this space. But in the radiology world, we are working against ourselves as it relates to radiomic and texture type analysis, because there are additional imaging approaches that are changing the fundamental way that these images look. Okay, so deep learning based approaches that are designed to make images more pleasing to the human eye, more contrasty, whatever it may be, are erasing these image features that we are trying to chase as quantitative indicators of disease. So a note of caution, if you're working in this space, this is something that you need to be paying attention to and understanding as we move forward. And I want to circle back to, again, these quantitative metrics that we think have promise for disease rely on having high quality imaging available. Okay, the poster that I had hanging up here yesterday, we looked through hundreds of patients to come down to a population that we could use of 23 patients because we wanted imaging during quiescent period. And we are not imaging our patients generally during a quiescent period. We're imaging them when they have acute attacks that are masking the features that we may be looking for to identify disease, to predict prognosis for the future, et cetera. And so we need a more broad, inclusive approach in this space. So how do we enable more imaging? Well, certainly we need to be a bit more standardized about it as well, right? Willy-nilly imaging of every patient, however we feel like, is not going to advance the field. We do need to be standardizing. So number one, stop doing CT without contrast, okay? I think we've probably got that message by this point, but I still see it far too much. Broadcast it to your referring colleagues, whoever it might be. Stop doing CT without contrast. But I think also it'd be useful for all the folks in this room, as well as elsewhere, to adopt a bare minimum MRI protocol. So not only do we see sort of suboptimal CTs coming in, but we will see substantial variability in the MRIs that we're getting, from things as fundamental as a number of sequences that we're getting. I'm not even talking about quality right now, but we've had exams come in with as few as 1 or 3 sequences and be called an MRCP, so to speak. And that's not adequate to make a diagnosis. And it's certainly not adequate to try and prognosticate about patients. So where's this, the literature in this space? There was a group, there's a group that's doing some study of type 1 diabetes, and they have developed a standardized MRI protocol for pancreas assessment in humans. They published that in PLOS One relatively recently, and you can see that protocol there. That protocol there is uniquely targeted at diabetes. It is missing some key sequences that are critical for making a clinical diagnosis, but it's there in the literature. If this is a space you want to work with, that would be a good protocol, but it's not going to get you all the way where you need to be for clinical diagnosis. Perfect, thank you. We recently convened a group leveraging folks who have previously been involved in Inspire or at Inspire centers to develop this bare minimum protocol. And this is a sneak peek of that table, of that protocol, which has been submitted for publication to hopefully begin to bridge this gap towards some standardization. And you can see that for non-contrast imaging, 5 sequences is all that are in here, 2 post-contrast sequences designed to make this implementable anywhere to give us all the information we need. So in summary, strides need to be made on optimizing the role of imaging in clinical care and being honest with ourselves about why we are imaging and what modalities we're using. So please do come at noon if you can. And quantitative imaging is the research frontier and requires CT or MRI. So we need to find a way to do more of this and do it responsibly. Thank you.
So we're going to extend a little bit by a few minutes the session, just so that we can take some questions. Excellent talks, and so I don't know if there are any questions in the audience. There's a microphone coming.
For Dr. Trout, you were talking yesterday. There were some talks on looking at healthy pancreas versus unhealthy pancreas using different weighting with the MRI. In the future, we're going to be able to look at healthy voxels versus voxels at risk, so we can help grade going from acute recurrent to chronic pancreatitis.
To some degree, that is what radiolink approaches do. They break the image down into the pixel level. And so we are contrasting healthy voxels versus unhealthy voxels and trying to understand the relationship of those to one another. So yes, we are moving in that direction, but we are also, as I mentioned, sort of self-defeating ourselves in that space. And I think we still have to really understand what the links are between the features that we are seeing and the outcomes of interest, whatever those may be, histopathologic or clinical EPI, endocrine insufficiency, et cetera.
Hi, Megan Golden from Mission Cure. I want to comment on the need for clinical trials and maybe provide some hope there. I think we have been really focused on disease-altering therapeutics, and we're getting close for both CFTR-driven pancreatitis and PRSS1, SPINK1, trypsin-dependent pancreatitis. And I'm suggesting, and I'll say in a minute what some of the opportunities are, but I'm suggesting that if we can collectively focus on 1 or 2 of those, that they're eligible for a pediatric priority review voucher. Those can be sold for $100 million, which provides fuel for future trials. And we have identified a number of companies that are actively interested in conducting these trials, developing the therapeutics, still looking for financing, and we're trying to help, but it's within reach. In the CFTR area, we've been talking to Vertex for quite a while. They haven't really committed to developing themselves, but I think there's a possibility of getting their drugs in appropriate cases. There are positioned compounds, meaning that they've been through at least phase, most of them through phase 2 for other indications, from Ariel and 2 others at least. And then on the PRSS1, SPINK1 side, out of the Wyss Institute at Harvard, there's an engineered protein. And this is, since I'm not a scientist, this is going to go over my head, but there's a whole website devoted to this pancreatitis treatment. And we're connecting them with some potential partners, but that's actually not that far away from clinical trials, and they've invested quite a bit in preclinical work. So I think that if we're not going to be able to do everything on your list, Aaliyah, but I think if we focus on 1 or 2, that we can really get there in the next year or 2.
All right. This is wonderful. Thank you for Imogen and the hard work on this. we have the cohorts. I mean, I think the pediatric cohort is, very rich in mutations and we want to focus. We will have to just focus like which patients to target and what drug. And I mean, certainly, funding is going to be very important for us, but I think we have to keep the communication lines open. Our patients our families are very open for this kind of treatment. Thank you.
Yeah, if I may add a comment, the time is now that after we took all these years and Aliyah and Mark have built this wonderful cohort, that I had a discussion with her last night. They need our help. They're at a point where we need champions, come up with good ideas, let's work together. And really, maybe we haven't had that big pediatric audience. This is like really amazing that this room is full. So it speaks kudos to everybody who has been pushing the field forward in pediatrics, such as Aliyah's voice. But at the same time, when a pediatric paper is submitted for review, and the journal editor sends us an email profusely apologizing that we invited over 30 reviewers. Some of them is reviewers you suggested. Please help each other. I always try to take 12 hours a week to help each other. And I do it because I want the paper to be easily read rather than say we shouldn't publish, because small cohorts are okay, single center studies sometimes are okay. This is how we generate hypothesis. Let's really help each other to elevate this field and volunteer to have an NIH study sections as well. Jose's in the room. It's really hard to get reviewers for each other. Pancreatologists, gastroenterologists, we need to get up there. We're trying to do the time for interventions. And I can speak on some ideas on acute pancreatitis, and maybe this is an invitation and even spurs a discussion. So the IV fluids are therapy, but also could cause harm. And we've done over a decade work in IV fluids, and fluids are always in the audience. So I answered the question, what is the rate? What's appropriate? We did kind of a mini waterfall, and then we made it safe. And then from there, we also randomized control trial for the type of IV fluids as a single, actually it was 3 centers, and now that's wrapped up, and hopefully we'll find reviewers and it will be published, oral versus normal saline at that fixed rate. I think moving forward, we really have to have a multi-center study for acute pancreatitis and interventional therapy, because I can show you data that a single attack could dictate the future of these kids. Whether they have recurrence, and it's within 4 months for the first attack, and the severity is what drives them to diabetes and exocrine insufficiency within the first year. So we could do better, and maybe we all can make a case. Let's join efforts. I'm working with the Netherlands people, that's Enrique de Madrid in Spain, and the Europeans work very well together. We're the United States of America, so we can do what the Europeans are doing too. This is a key. If you have a acute pancreatitis, within your center, all I want to do is to say, I'm in. What is the total number of admissions of acute pancreatitis in your last 3 years? We're going to put some good data together. We're already worked on this for a decade. And I think the time is ready to move the field forward. We're associated with imaging, because I totally agree with you, and that's the way to do it. Research, document imaging, that's how we need it to be a perspective, randomized clinical trial, and then imaging afterwards. But if we do imaging afterwards, we need to define those outcomes too. I'm not open to discussion, but it's really in the works and brewing. Any comments on my long? Should I move forward or pause? Anything else from anyone before we move to the case discussions?
I had a quick different topic on CFTR, maybe for Aliyah or for Tom. So CFTR mutations are so prevalent, in our patients with acute recurrent and chronic pancreatitis, but of course there are over 2,000 variants. And is there something that we can do for testing the functional test of CFTR beyond sweat. I mean, the nasal potential or intestinal current or other ways of looking at CFTR and their impact on our patients with pancreatitis?
Very good question. I think this is an intense area of research, and there are some papers coming out, and I mean, there are some centers that do NPD. I think there are about 5 centers that do NPD. There was a poster about beta adrenergic test. I mean, you can look at that. I mean, perhaps just compare that. I mean, there's definitely, intestinal organoids that you can take. I think there's some papers coming out. I mean, we can't take the organ and take a look. I mean, that is always a problem with the pancreas. I mean, certainly, there's genetic testing. Certainly, there are certain mutations that is associated with the pancreatitis causing CFTR-related disease. But that's an intense area of research.
Comment from the type 1. Okay, then I'll make a comment from the type 1 diabetes world, actually. And it pertains to clinical trials in chronic pancreatitis. It's just something to consider. One of the things that happened over the past 15 years in the type 1 diabetes community, which maybe the one other pediatric endocrinologist in the audience here might be familiar with, is that there was a desire to intervene, right, and halt the progression or save beta cells in type 1 diabetes using immunotherapy. And clinical type 1 diabetes was advanced stage disease, right? It was that you had, hyperglycemia. And over time, there was a conceptual model developed that actually diagnosed diabetes earlier and divided it into very clear stages. So there's stage 1 disease, which is you have multiple autoantibodies, but you don't have any dysglycemia. Blood sugars are very normal. Stage 2, you have autoantibodies and dysglycemia, but don't meet diabetes. Stage 3, you have diabetes, but you still make C-peptide. Stage 4, you're no more C-peptide, essentially no functioning islet cells. And it's a very nice framework for intervention trials because it defines stages of disease very clearly. And some interventions in terms of trying to protect beta cells are now actually being developed to maybe more successful at the earlier stages of disease, at the stage 2. And it's a little harder to define what those stages are in chronic pancreatitis, but I think there's an analogous situation here, right? Where you have acute pancreatitis and recurrent acute, and then chronic, and then end stage disease. And if we can make a conceptual model that defines that very well, then I think that helps you start to be able to plan where the interventions are. So that's just my thoughts from the type 1 diabetes world.
Yeah, I think it's also so important that, in our field, endpoints and outcomes, whatever we do, we have to define for every treatment that we do. I mean, that's something that is missing for our field. What are our treatments and what are our endpoints and outcomes? And that's, something that I'm looking forward to for every trial that we do. What is that we want to do? If we are targeting that we want to reduce the number of acute pancreatitis attacks, that is our primary endpoint, but what other endpoints that we are interested in?
I am going to circle back a little bit to what Andres asked about CFTR and how I think with hereditary pancreatitis, we need to be careful with sort of this idea of point of care testing. So with CF in particular, there's a couple of different skin tests. There's exhaled breath condensate, other things that people are working on. But the problem is we know with CFTR expression, it's variable in different organs in different places. And so making that comparison that you see a change in a skin test or an organoid and knowing what that's going to do in the pancreas or anywhere else in the body, we don't have those associations. And even if you look at the very classic ones like FEV1 and your sweat test, they don't go together very well. And so I think even when we think about SPINK1, PRSS1, whatever it is from a hereditary standpoint, when we're trying to find an indirect marker, keeping that in mind is going to be very key. And when we think about that from a study design standpoint, showing those associations is going to be critical if we're going to be able to make that leap. It's going to be very difficult, But I think we can use CFTR as our example, understand why that's a challenge, and then think about that as we move forward. So just wanted to add that a little bit.
Yeah, I totally agree with Jay, but I think maybe that would say we emphasize on understanding imaging patterns better, because maybe that is an end outcome measure that we could follow objectively, because you have that as a phenotype rather than function, and kind of starting to probe that. Any other questions for while I'm here, before I move away with the microphone? Yes.
Andrew, Dr. Trout, great presentation. Can you tell us a little bit about how you would propose to apply radiomics to the INSPIRE cohort in terms of assessing its outcomes and its utility?
So a couple of quick thoughts on that. We're going to struggle with the heterogeneity piece there. So that's number one. The heterogeneity in the imaging is going to be an issue. But I think at a base level at first, I think one critical piece, we know, as I mentioned, that in terms of just the base imaging features that we associate with disease, there's a lot of inter-observer variability. And yet the data that is logged in the INSPIRE database is based on local interpretation, right? And so I think we need to do a bit of spot checking of those data in a very sort of controlled manner, where we can then link with outcomes of interest, whether they're EPI, whether they're genomics, whatever they may be, linking well-curated imaging features with that. Once we start to see some of those imaging features there, then we can begin to explore the application of radiomics. But I'll tell you, for example, Temel yesterday was talking about T1 signal intensity ratio, which is a very simple thing. That's not even radiomics. I have a summer student working who's basically shown that across 3 different imaging sequences, you're going to get totally different values. All T1 weighted sequences, just acquired in slightly different ways, you get totally different values on those different sequences. So it's not as simple as it appears on the surface. And so I think we have to have a sort of very dedicated and careful approach to digging into this and doing this in a very structured, organized way. And so to Melena's point, I think this idea, this conceptual model would be very useful in terms of helping us to bucket different imaging features that can be found at each of those different phases and link them to genetics and or outcomes, clinical outcomes of relevance and importance.
So in PROCEED, which is the adult cohorts, the imaging studies prospectively collected are uploaded to the Data Management Center database. This is something that INSPIRE has not done. So going forward, this is something that we will be doing, which is the uploading the images prospectively. But this is a great resource for the consortium. But then you have to curate all that data. So I mean, right now, as Andrew said, I mean, we rely on the local interpretation. I mean, INSPIRE 2 data that is reported just relies on the local radiologist interpretation, and there is not always a consensus about the interpretation. I mean, this is something that we're, finding out. But just going forward, this is going to be available, but then you need understanding and resources in order to curate that data.
Okay, with that, we end the first section. So thank you to the speakers. And we have some case discussions next.
Sorry for the change of plan, Madura, on you and the next 2 speakers, but we felt that we cut short the first one. So maybe if we can make like 20 minutes with a discussion for each, if that's okay.
That's great. Okay, so good morning, everybody. Can you hear me? Okay, good morning. My name's Madura Fadki. I'm a pediatric gastroenterologist and pancreatologist right here at Children's Hospital of Pittsburgh. I have the pleasure of moderating this portion of the session today. So we're going to have about 20 minutes for the talk and for the discussion, and we're going to try to incorporate kind of discussion, comments, questions during the talk. So our first speaker is Dr. Jay Freeman, who is a professor of pediatrics at Nationwide Children's Hospital in Columbus, and he'll be starting our first presentation.
Thank you so much. This is really embarrassing, Andrew. My whole talk is about non-contrast CTs. At least I was listening. No, so hopefully I have an interesting case for you today. Pancreatic mass in a child with the somewhat Rene Romero influenced talk from EDW, if you were there. Should I stay or should I go? I have these disclosures, none of which are really pertinent to today's talk. So I'm going to take you way back in time to February of this year. We had an 18-year-old female who had a past medical history of JIA and Smith-Magnus syndrome, which I know everybody in this room knows everything about that, but just as a quick refresher if you need it. This syndrome is associated with short stature, cognitive development issues, curved spine, raspy voice, probably a good lounge singer, limited sensation and pain for some patients, and some hearing and vision problems. But maybe most importantly for us is this excessive weight gain in adolescence. So like I said, 18-year-old who actually had a liver biopsy about 10 years prior with some early fibrosis, and was sent to one of my hepatology colleagues because they had been lost for follow-up, and they were worried about fatty liver disease. And here we are at Pancreas Fest talking about fatty liver disease because it's just everywhere, right? Patients on a beta set for their JIA, and you can see their transaminase levels that prompted referral. And so, unexpectedly, my hepatology colleague wanted to get some additional imaging since we've been lost follow-up. We had some degrees with fibrosis, even though that might not be the best imaging choice. We wanted to start with an ultrasound because that's what insurance will give us. And the first surprise was they declined the ultrasound and let's have an MRI. Yeah, study done, I'm out.
What was the insurance?
Yeah. But so we skipped the ultrasound, no CT. We had an MRI. And this was the first surprise that sort of came out, was this enlarging cystic lesion in the tail of the pancreas. It's measured about 2.5 centimeters, of which they recommend MRI with contrast. Well, again, I'm not at this point, but at this point, nobody's ever talked about a cyst in the patient pancreas. And so I get a phone call and, Jay, can you help? It's not just fatty liver disease anymore. Oh, sure. What's the first thing you should do? We should go back and look at the last imaging, right? And so we're going to start off with this little guy right here. You can see him. Yeah, exactly. So even the radiologist can barely see him. All right, maybe it's fast line, whatever. But anyways, we see this small thing, and they do note it. So it's small cystic lesion, distal body. It's not seen on prior imaging. Like I said, this patient's been followed for around 2 years. But interesting what we're finding. So obviously, we're wanting to move forward. This patient, for their JIA, was actually admitted after their initial MRI to get further imaging for their JIA. So luckily, they were held in the hospital. And we were able to kind of expedite some of this stuff. Obviously, with some of the cognitive issues and weight and some other things, they were needing sedation for these imaging and stuff like that. And so I think it's pretty clear, but I'll walk over to my pointer. But our little guy is now turned into a pretty big guy, right? So we definitely have some progression here. So these are our pre-contrast imaging. So an axial T2 and an axial T1 are shown here. And then just because I knew Andrew would be in the room and he'd help me otherwise, we have a post-arterial phase and post-venous phase so we can better characterize this thing. So I do like the swinning, and this thing looks a little weird. It's gotten a little bigger in a couple of years. And obviously talking about this with our radiologist, everybody's a little perplexed. But here's the read, and I think where things got a little interesting to us. So this thing went from 0.5 centimeter in 2019 to 2.5 in a 4-year period. So pretty significant progression, I would say. Consistent with a mucinous cystic neoplasm, patient is below the typical age range. So this room consists largely of tertiary and quaternary pancreas centers. How many of you have seen an MCN in a child? Otherwise, the pancreas looks pretty good. Main differential is these things. And really at this point, we're thinking we missed pancreatitis somewhere. this is, more consistent with maybe a pseudocyst, is this it? So we're trying to go back and try to get some history. And our radiologist nicely put, if you don't aspirate this, then this is when I would follow up. Nudge, nudge, go aspirate this, right? So just kind of a brief pause looking at some of these NCNs, IPN, ASCNs, I'm sure your serious cystic neoplasms. You can kind of see the location of them, you kind of get this idea of the size a little bit. But when I think things to think about are these genetics, which we're going to get into. And what I'm not showing here is age, right? So NCNs are almost always 40, 50, 60, 70-year-old women. So 95% female predominance, much later in life. So why those words kind of scared us a little bit. I think really at the end of the day, we thought we were missing something. That certainly could be what we're dealing with. Luckily, we have this nice paper from just a couple of years ago that Andrew is on, Jamie is on this paper, sort of common and uncommon pediatric tumors we should be thinking about. And sure enough, NCN, some of our other ones are there at the top, but then there's all these other things that we really should be looking for. And most importantly, from this paper, specifically talking about cystic neoplasms, a single pediatric PCN has been reported in the SEER21 database, and fewer than a handful of these tumors have been reported in relatively recent published literature. So I don't know about everybody else in the room. I've seen a lot of spins, I've seen a lot of simple cysts, I've seen a lot of other things, but it starts to really get to this idea of when you have something that looks a little bit abnormal, where do you go? The literature tells us it shouldn't really exist, or if it does, it's a handful around the world. And how do you develop a plan based on something that shouldn't exist, if that is what it is? And how can you be comfortable that it is or it isn't the thing that you're worried about? All right. So now this family's scared. They've read the report. They've Googled this. They're finding all these things. So our job now, obviously, is to try to figure this out. Do we really have something serious? Do we have something that needs to be whacked out, or is this something that we can just keep in? So Dr. Khan in the back, I feel like my presentation is just presenting everybody else's pictures, but that's okay. So luckily, Dr. Khan back there was able to do EUS, and we have this lesion here. I was showing you got the lesion here with the septate in it. That's showing up back there, I'm not real sure. And then this is just the needle going in, and as you can see, again, it matches the size. So here's our markings in centimeters. And again, you got about a 2.5 to 3 centimeter lesion here that does appear to be cystic with some septate in it. And so what do you send from the fluid? I think becomes one of the questions. And I think historically, we've thought about CEA as some of our tumor markers. But more recently, we're starting to think more about the genetics and the molecular approach to these type of masses. And so this is a paper that just came out earlier this year, looking at really the use of the molecular markers developed here in Pittsburgh, actually. And so they did this really wonderful study. It's something everybody should take a look at if you haven't already, but it's Pancreatic, where they looked at 22 cyst genes. And they started this out with a retrospective approach to identify the genes of interest. And then they did this in a very prospective way over 2 years, where they looked at, almost 2,000 specimens from, around 1,900 patients. And we're able to identify those molecular markers and those genetics that are most in keeping with benign versus malignant cysts. Do not expect you to look at all of this and look at all the data, but I think what is important is the work that they put into characterizing these patients. We have the clinical features that they have looked at on the top. We have all the genetics pre-resection of these tumors and then post-resection. And so there's a huge amount of data that they got from these roughly 2,000 patients, where they were able to synthesize, what they should be doing with this. They also did a huge sensitivity specificity analysis with all the different levels of analysis they could do for these different tumors. And again, the importance isn't the numbers on this chart, but just the detail they went into. But if we look for just specifically these ones that we would think of as being more concerning tumors, those that might have a cancerous outcome, you start to see that with these mutations that they've identified, you've got a sensitivity of 90% with a specificity of 100, positive predictive value of 100, and a negative predictive value of 77. Compare that to just the CEA, which is kind of the historical. This is the classic thing that people have been doing for years. It's not bad. Sensitivity of 73, specificity of 94. That's a cutoff of 192. It's a very weird cutoff, but very specific, 192. And again, you see the sensitivity, specificity, positive, predictive value, negative predictive value. So it's definitely better with the genetics. Something to think about. But with all that kind of, I do like how they synthesize this and finally put it into a picture for me that I could actually understand, right? And so really the approach now from the adult pancreatologist endoscopist standpoint is really you go in, you get fluid, you look for these genes, and then you categorize. And there's less importance put on things like CEA and our classic markers that we've used in the past. So with that little, jog down that path, we got a CEA. It's over 11,000. Again, cutoff is usually 192. So a little high. Definitely got our attention. We did some genetics. All the ones I just showed you on there were normal. And then we had somebody actually look with their eyes, looked at the cytology. They looked to actually the adult pathologist over at Ohio State, had them look at it. They basically said it looks normal. So I'm a little confused at this point. I don't really know what to do. We're discussing this in our radiology meetings and different things. And we're going back to little tables like this. We're like, okay, again, age doesn't match, education is there. We have the genetics that's normal. That's what everybody's telling us we should do now, but we have our old school marker. It's wrong. What should we do? What are other testing we can do? And so it just happened that around this time, it was time to go to DDW, right? So we go to Chicago, and there was one of the experts from Hopkins, and she was giving a talk. And you may have remembered, I stood up and I asked a very simple question. All of this is done on 60 and 70-year-old women that you're presenting. How do I use the data that you're telling me in an 18-year-old kid? And she said in front of everybody, if the genetics are normal, I would discharge them from my clinic. So I went up to her afterwards and I said, hey, I'm going to give you a little bit more detail. Like this patient has a CEA of 11,000. Like, that's pretty high. I know you didn't have all the details. That's not fair for me to ask you in front of everybody, but with a little bit more clinical information, what would you recommend? Discharge from your clinic. This is what's in her head. So 18-year-old, possible NCN. None of you have seen it in this room. I've never seen it in this room or in any other patient. Who's sending this patient out of their clinic to follow up as needed? All right. So I agree with that. I didn't like that answer. On the Likert scale, I was everything bad. I was not at all satisfied. Wow, I'm grumpy, but geez.
Sorry.
Feelings a little hurt. It's okay. And I can't get this out of my mind. And this is the reason I'm not satisfied. So, other things we could have thought about. I don't know how many of you have access to needle-based confocal laser endomicroscopy. So I actually reached out to the adult guys. There is one of our adult colleagues who has an R01 looking at this. And he's like, sure, just send them over to OSU. We'll be happy to put them to sleep again with anesthesia on this 18-year-old who's already got these other comorbidities. And we kind of discussed amongst our group, and even though all these images are really cool, and I'm sure they're really good at doing this, and they might have been able to give me a really good answer, at the end of the day, I just couldn't think of any piece of information they were going to give me that was going to really change my mind. And so quite frankly, we skipped it. So my son gave me 30 minutes for this talk, 15 for me and 15 for you. So this is the discussion part. So your options are discharge from clinic, which I think we've already said we are not very comfortable with. You can say that we're wrong. We should have gone that confocal. We can do sort of what the radiologist said and repeat a scan in 6 to 12 months, or you can take this thing out. So I'm going to poll the room eventually, but I will stop and see if anybody has any questions or any other comments based on the workup and approach so far?
There's no other cysts anywhere else, right? Kidneys or liver, anything?
No, we do have full imaging. So like something like a VHL or Lindau, something like that doesn't look to be going on. They did actually have genetics earlier where they didn't have any CF mutations. I don't remember exactly why. It may have been a cholestasis panel actually for their liver stuff. So like pancreatic cystosis isn't really on the differential at this point, as we start kind of thinking through things like that. But no, it's just this one.
We don't know the relationship with any blocks or any branches.
Yeah, so specifically, we can't see directly, we can't follow the duct into it. It does not appear to be more of an IPM, the ductal, involvement, but we can't definitively say.
Jay, when the cyst was aspirated, was it aspirated completely dry? This could be a question for Mohammed too. Did you aspirate all the fluid out? And then since then, has there been any follow-up imaging?
So I do not believe you did all of it. It was just a simple. Never mind, I don't know.
Has there been follow-up imaging
Any
after
follow-up
that?
imaging since then?
Can you clarify?
She is cognitively delayed for sure. I don't know. I mean, her life expectancy is probably a little bit shorter, but I don't think strong by any means. This isn't something that she should only make it look on fine. But I would expect her. I think is a wonderful question. I think that really ties into the disconnect between what we have to do in our job and the literature that's out there.
Just want to clarify, is the patient able to report symptoms? Like, does she have symptoms related to this, or is she able to report cognitively like symptoms, or she's asymptomatic? Okay.
We certainly talked about that as well. Well, I mean, I think that's part of where my next slides are going to go for sure. But I mean, I think that's the question, right? I think it's real. I mean, and I think it's perfect segue into what we're talking about. I mean, you've got adult insomnia, just ignore it. We have a lot of questions that like, how can we possibly characterize this thing better? And quite frankly, I'm just kind of where you're at. What information, what sample are you going to give me in a kid who I expect to live for decades longer is going to convince me that I can ignore this or simply get something every 6 to 12 months? Mohammed?
Sorry, I didn't want to shout again. To answer Roberto's comment, so when doing the EUS, I used a 22 gauge FNA needle and tried to take some samples on the opposite wall as well. So I think the cytology represents a little bit more than just the fluid, but maybe capturing a little bit of the wall. It's not as good as a biopsy. It's not as good as endomicroscopy, but it is a little bit more data. So our cytologists will determine if a mucin stain is needed based on what they see first. And then if they do, then they stain. They didn't see anything that they thought would need a mucin stain. But this is where I thought it would be mucinous. And certainly the fluid that came out seemed lightly mucinous, but not like a string test that was positive that I could hang my hat on.
We have time for one more question, then we have about 5 minutes to finish this one up.
All right.
Can she have, okay. Is this going to be one lesion or is she expected to have multiple lesions?
No, so much. All right. So, yeah, you have
Thank you. I'm Yuhua Zheng from Children's Hospital, Los Angeles. So recently we're actually working together, try to put the pediatric pancreatic cystic lesions like all together. And so apparently the one you're just talking about, the mucinous and the cystic neoplasm is extremely rare. We were only able to find one case report. I think it's 19 years old and with the cystic fibrosis, and they actually have the cyst. They found the cystic lesion, and then they did not resect until like 13 years later. So I think according to adults, and they said there are 25% of a chance become malignant, and because of high chance for malignancy, they do recommend to refer to surgical resection. So that's the only thing. I don't have any patients. So I'm ready.
So sounds like we're all taking this serious. There's a round of surgical versus. So our approach was we decided it had to go.
Okay. So, I mean, I think that, you know, you've presented a lot of great information about how we evaluate pancreatic cystic lesions. And I think that, you know, what you're really driving at here is that CEA is what's high. And, you know, while we have newer markers and newer tools, they're all developed, like you were saying, in elderly adults.
Yeah, let me get there, Mom.
Okay. Sorry.
All right, we're good. All right, so we decided it had to go. The same ideas that we're talking about here, you, Holland, and I saw. This is a paper that I think we published. I don't think it's much of an issue, other than we felt like we could really get this out by only about 50 to 65% of the total pancreas fund. And so Dr. Nathan Becker was able to do this through a robotic approach. Obviously, that's the mass. Kind of pulled up, and this is what this thing looked like interoperatively. Cool pictures, but I think they're all pretty self-explanatory. Able to staple across there, and was able to get statistical pancreatectomy. This is what the thing looked like once it was twisted out. And the histology shows a fibrous capsule wall stroma that is then magnified on this side. The feature that I pulled up here is the ovarian stroma, and this brown dye over here is actually a progesterone positive state. So this is a classic histological feature of an instant. This is the intermediate to moderate dysplasia of the ductal cell. This is that eosinophils along the outside here that are abnormal, and you can look at the nuclei of the cell. There's a lot of dysplasia. There's some turnover. This thing looks relatively nasty for an 18-year-old who potentially have to live the rest of our life. So not even money. So the question is, if we have approaches like this is what I've been getting to. This is just one of the many approaches that will say, you characterize these lesions, use the CEA, use the molecular models. And my question to you is, does it? Is there any way that we can use one of these algorithms that at the end of the algorithm, it says monitor for 6 to 12 months, or one of them says resect if young and healthy? Actually, kind of agree with that. You know, these patients have good surgical outcomes. And I think this is where we are going to operate. So unlike many of the models where we have bullet points, I don't want my conclusion. I really don't. I think the ideas of tertiary and quaternary centers that are going to see weird things and complex things, we have to be able to operate in the gray a little bit. We have to share our experiences with each other. And as long as we can make a sound medical decision and really justify why we're doing things different, then I think it's perfectly. So hopefully I didn't go too far over. This is a thank you to our team. We have this wonderful pancreas team that's growing. We're happy, we appreciate everybody's help. Obviously, there's a ton of people who were included in this, including Mohammed and Dr. Nathan, a whole team back there. And so I'm happy to discuss. Are we ready to live? Thank you. Okay.
All right. Thank you, Dr. Freeman, for that wonderful talk. And that certainly sparked a lot of discussion, and more is ongoing, it looks like. So that's great. Our second talk is going to be by Dr. Megha Mehta, who is a pediatric gastroenterologist and assistant professor of pediatrics at UT Southwestern in Austin, Dallas. I'm so sorry. I knew that, Dallas. And you're going to take us away for our second talk from Dallas. Thank you.
Today I'm going to present a pretty challenging case of food pancreatitis. This patient is actually still in the hospital. I have no disclaimers other than I have a lot of questions, hardly any answers. So I'd really welcome any thoughts from the audience. So it's a 12-year-old male with complex past medical history presenting with tachycardia, abdominal pain, distension and bilious output. It was sudden onset of feeding intolerance and distension. They bended his G2, got 870 cc of bilious output out, had belly pain that didn't respond to ibuprofen, hiccups. He has a Nissen, so he didn't actually have any emesis and hung his stool. Past medical history, like I said, very complex. He has hypoxic ischemic encephalopathy in utero, spastic paraplegia, he's orbital delayed, nice gastro, trachea, G2, Nissen, you name it. Family history is largely just notable for cystic fibrosis, spondylitis. He's on a number of medications relevant to us, antiepileptics, clobazam, valproic acid, diazepam. He's on baclofen, gabapentin, Nexium, Miralax, nebulizer, etc. Initial labs, the CBC, CMU were all normal aside from an albumin of 2.5. His lipase was elevated to 90. Our upper limit of normal was 93. CRP was elevated 6.1. After yesterday's talk, I went back and got his procalcitonin. It was 0.1, mildly elevated. His infectious evaluation was all negative. We got the usual chest X-ray, KUV in the ER that was all normal, and then the CT because this kid is delayed. We really don't have much of an exam on him. They found that he had marked inflammatory changes in the duodenum with surrounding fat stranding and fluid. Could be consistent with duodenitis. There was also heterogeneous enhancement of the head of the pancreas. And the third segment of the duodenum here, which could be reactive versus restrictor. He's had previous CTs that have been shown in the So here is his CT. So you see stomach here, going into our duodenum, and already it's a little bit of free fluid. Here is duodenum, here is the head of the pancreas that was the more heterogeneous. So free fluid, fat stranding here, and so some still fits here showing us the same stuff. So edema, free fluid, fat stranding, pretty prominent pancreatic duct, and then some heterogeneous enhancement of the head of the pancreas. So next step, given this question of duodenal neurite and upper GI small bowel follow-through was obtained, again it showed gastritis, thickening of the gastric wall, possible duodenitis, no evidence of obstruction. So then, as gastroenterologists do, we did an EGD, and his EGD was pretty normal, aside from the duodenum that looks rather swollen. And the path came back as well. So here's a picture. Here's a picture. We're in the bulb here. And now we're making our way into the second portion of the duodenum here. And this is with maximum insufflation. You can see that duodenum is really not insufflating much. It looks pretty edematous. And down here is actually where the ampulla is. So it's displaced, I think, from the duodenum itself. And I confirmed with David Trendle, he was in the right location. So in summary, we've got evidence of pancreatitis. There's heterogeneously enhancing head of the pancreas. His lipase is elevated. He's got abdominal pain. This question of duodenitis, there's edema, but the histology came back normal. There's evidence of fat stranding fluid on the CT. So if you put all this together, it sounds like a condition called pancreatitis, which admittedly I hadn't heard of before. So it's also known as paraduodenal pancreatitis. It's focal pancreatitis with fibroinflammatory process involving the pancreatic liquid to improve. In its pure form, it's just an improved, but there's a segmental form that also involves the pancreas. And it could be cyst-forming or more of a solid fibrotic appearance. And then there's a third entity that's more ill-defined with kind of diffuse enhancement of the pancreas and the dilated. It's a very variable presentation. Acutely, they can have belly pain, nausea, vomiting, gastric bowel obstruction with our patient, or they could have a more chronic indolent process, which on this is weight loss that would be concerning with cancer. It's a long duration, 3 to 6 months, and then interestingly, the enzymes could be normal or minimally. If tissue or if sampling is obtained in FNA, spindles from those cells. And then the support is largely, the management is largely supportive, rarely surgical. Why does this occur? There are some theories. One theory is that maybe there's a topic pancreatic tissue in the vaginal wall that's immature and doesn't have a ductal system, so the fluid collects and leads to local inflammation. Another theory is maybe there's a problem with the minor papilla. Again, there's no sphincter there, so maybe there's insufficient drainage that leads to fluid collection and inflammation. And the third theory is maybe there's a completely separate inflammatory process like peptic ulcer disease that can drive this. So there's not a lot of literature. There's no pediatric literature. The largest series I could find was recently published in 2021 that looked at 40 adult cases. It's in middle-aged men, not our patients. All pain, nausea, vomiting. 92% meet criteria with acute pancreatitis. Heavy smoking and alcohol use. Half have a prior history of acute pancreatitis or chronic pancreatitis. And the imaging findings are pretty similar to what we saw in our patient. But interestingly, in terms of follow-up, 14% ultimately required surgery. But more importantly, there's a high burden of pancreatitis-related readmissions, so 69 per 100 patient years, and 29% went on to develop chronic pancreatitis. So I'm going to stop here and just poll the audience. Has anyone seen group pancreatitis before? Mohammed, what's your experience with it? Not to put you on the spot.
I see it a lot more in adults when we're doing, therapeutic ERCP for gallstone pancreatitis, and there's acute pancreatitis. I've seen it in some teenagers as well. It's a spectrum. When I've seen it, so I'll see very mild duodenitis and just some edema, and then kind of get really bad. The reason I know it is because it makes the ERCP that much harder, because you really lose sight of the papilla. Basically, everything looks like a papilla.
As my next question is, have you considered an ERCP?
Have I considered ERCP?
Yeah.
So I'll get into it, but
okay, sorry.
Of doing anything further.
I have a question. So you said there was a lot of biliary output in this patient. So how did he present? Did he present with biliary output? How long has it been in the hospital?
So he presented from home with acute onset of this bilious output. So just all of a sudden started having feeding intolerance. Looked, he's delayed, but he looked agitated. And so they tried to vent his G-tube and got all this output. Well, very acute onset.
So the background of this patient is neurologically delayed.
Vent, G-tube.
Yeah.
Spastic
so I missed it perhaps. Did you do upper GI?
We did do an upper GI small bowel that showed no obstruction. And
no obstruction.
We also didn't see any obstruction, just the light.
So issues with the motility, gut motility?
No underlying issues. This kid was G-tube fed, so it's not like he had a GJ. He really wasn't followed by GI, in those complex care. So up until now, really no obvious GI hypomotility.
Yeah, I think, some of those things we see, pancreatitis could be seen related to the obstruction or intestinal pseudo obstruction. I think it's the primary problem is with his duodenum. And, with all this, issues with things backing up, I think that's the problem. And, is this a SMA syndrome? Is this a motility problem? I think until that is fixed, his pancreas is probably not going to get any better. Yeah. So I wonder if there are any issues with that.
We definitely want you to get through your slides, but is there room for one quick comment?
Yeah.
Okay.
So quick question. When Dave went in and did the upper endoscopy, did you guys consider EUS? Because with that dilated PD, sometimes on the imaging, when there's inflammation, you could, miss a mass. And so that might be one thing to think about.
Yeah, great question. Honestly, at that point, we weren't even really thinking about it. I think we got a little bit, blinded by the question of duodenal obstruction and duodenitis. We're really focusing more on the duodenum at that point in time. And then the path came back normal for the duodenum, so that kind of gave us a puzzle. So after the EGD was done, we got additional evaluation. His IgG4 came back elevated at 288. The CA19 were normal. And we got an MRI at that point as well. And so similar findings: extensive paraduodenal peripancreatic inflammatory fluid, concern for pancreatitis, focal duodenitis, focal duodenal wall thickening, hyperenhancement, some upstream dilation, and then a new finding of heterogeneous intraliminal contents within the distal duodenum and jejunum that was concerning for duodenal hematoma. Good job, David Trimble. So here's our MRI. Very distended stomach here. We're making our way down here, and pretty soon you're going to see the pancreatic duct. Here we go. Making our way here, and our bile duct is going to come here. And you can see that there's definitely some fluid and some inflammatory changes here, and concern for hematoma here. And I have a much easier time looking at CT. So here's the CT we got about a few days later. At this point, his G-tube had been converted to GJ, so that's his GJ here. So we're pretty distal in the duodenum here, getting closer to jejunum. You can see large fluid collection here, and I didn't have this picture, but there was some up here as well. And it looks heterogeneous. That was concerning for blood. And so now we've got a kid that we think has group pancreatitis. We know at least he had pancreatitis on admission. Lipase was elevated. He had abnormal features on imaging of the pancreas. There's this question of autoimmune pancreatitis that I'll get to in a second. He's got huge duodenal hematoma, and we don't have much to examine because he's very delayed. So our management was largely supportive. We did hyperhydration for 36 hours. Even with the GJ, we were really not able to advance feeds at all. Anytime we tried, and get very agitated. So he's been on TPN for 2 months now. And had a lot of pain management involved. He even got ketamine infusion, PCA. Currently, he's on gabapentin, methadone, Valium, and mirtazapine. Here's just a trend of his lipase that was done, at different times. So this is admission here. His peak was about a week later. This was kind of a few days after the hematoma formed, so maybe that could explain it to Leah's point. And then things resolved. There's another mild peak here, not above 3 times upper limit, but this was around the time that we started feeds again for the second time, and we had started bringing steroids that I'll get to. And then he got very agitated. We started to see his peak, a little bit of a jump in his lipase, but then it actually went down the very next day and stayed below 3 times upper limit since. In terms of the management of the feeds, his G-tube was converted to GJ, trying to bypass the duodenal hematoma to allow us to feed. But again, we were unable to advance in no feeds. He had persistent high gastric output all this time with really slow resolution of the duodenal hematoma. We got a CT 6 weeks later. And play. But, oh, there it goes. Okay, so CT here, GJ tube starting here, which helps us look at the course of the small intestine really nicely. Here's fluid collection here, and then this is the very large fluid collection here. The inflammation in that groove is maybe a little bit better. I would say not significantly better. But at this point, our radiologist took a look at this and they said, it really doesn't look like blood anymore. And he's still having this output. We can't feed him. We think maybe this might be contributing. So we talked to IR and got them to do an ultrasound guided aspiration. They got 82 cc's of really nasty looking fluid out. Doesn't look like old blood to me. Cell counts are here. We tried to send amylase and lipase from it, but it was too viscous, and so the test was unfortunate. And so back to that IgG4 that's elevated. Show of hands, anyone think this patient actually has autoimmune pancreatitis? I'll tell you, the literature suggests no association between group pancreatitis and autoimmune pancreatitis.
I mean, I've never seen pancreatitis.
Yeah.
I mean, it's a thing that we think of in adults, and the chronic reason it comes up in adults differentiation pattern.
And so, yeah, it's local pancreatitis with spot. It just doesn't make sense. So something like that. And anytime something doesn't make sense to me, autoimmune is one of the things that I'm doing.
Yeah. Any other thoughts? It did. You know what it is?
The EGD was a routine EGD, got biopsies, but there was nothing complicated about it. You know, there was edema of the duodenum, path came back normal. The question I think is, did that put him at risk? But this is a typical EGD. So prior to developing hematoma, prior all of this, I will say I didn't add it just because it complicates the picture, but he was admitted a few months earlier with, again, like distension type issues. But at that time, pancreas, all that was normal, was there for a few weeks, got better, came home, and now he's coming back.
Good Lord. Did you do any angio or angiogram to see what that means?
That's a great question. We did not.
You know, I think I would agree that it seems like pancreatitis with complications rather than a primary problem of like a groove pancreatitis for whatever it is as a pathology. IgG4, you've got a lead, you might as well treat it. Actually, you're going to treat it on the slide. But but for a kid who's got a neurological devastation, multiple comorbidities, the other thing just to think about is the multiple medications. And is there a contribution to pancreatitis from some of these medications?
Yeah.
What's the range of IgG4 in your
what's the range?
Oh, is this like 2 times the upper limit? No,
it's not 2 times.
It's not even.
It's not 2
times.
times.
Like if you had some imaging and 2 times, then you could combine them together. But all right.
Yeah, I disagree with group pancreatitis. I think this is a bad motility, bad duodenum. I mean, those kids just have paper thin duodenum, and then you may have a perfect EGD, and then they bleed, they have duodenal hematoma. So I think just one complication after another, and it's just hard to put them back on their feeding again. And I mean, pancreatitis is not all that overwhelming. And it's just like you get a duodenal hematoma, you get pancreatitis from that. So, and then you just start chasing your tail, and IgG4 is not all that elevated. And then you start chasing that. I mean, a patient in the hospital, and, you know, what do? I mean, you have to establish the feeding to the best of your ability. I think it's just bad motility in a kid who wasn't having a normal motility to start with, from my understanding, and then just complication.
Yeah, I mean, absolutely. I think that's what's been tricky. He's got this question for pancreatitis, this question on autoimmune pancreatitis. He's on valproic acid. Is there drug-induced pancreatitis? He now has a hematoma. Is that exacerbating his pancreatitis? He's medically complex. Is there just some underlying issues with the GI tract? Because our chief issue now really is inability to advance feeds, and then also pain. But then the question is he actually in pain? Is this mom's perception? Is this stormy? Is this something else? It's a hot mess. So we did try solumedrol for him because we had nothing else to try. We started at 1 mg per kg. Initially, we started tapering a little bit quickly. We did IV solumedrol for a week and then switched to Enteral. He seemed to do fine until that bump a month into the hospital stay I mentioned earlier. At that point, we went back to 1 mg per kg and slowed everything down. You know, if this was IgG4 related autoimmune pancreatitis, he doesn't have any other IgG4 related disease manifestations. And you can see the trend of the IgG4 here. And so some discussion, I talked about group pancreatitis. We talked about if this is or isn't autoimmune pancreatitis. But one question for the audience, would anyone actually try to get a biopsy on? We elected not to do US guided biopsy when the IgG4 came back. We were Dave was pretty concerned about seeing an infection or risking more complication. At that point, you already have the hematoma as well. Is there any utility in biopsy now that he's already been on steroids? Would this change our management at all?
You don't have any thoughts?
How long?
2 months.
Yeah, you're not to find it.
Yeah.
Even if it's autoimmune.
No.
Yeah, so it's not autoimmune. So then it's not autoimmune. Autoimmune, you improve within a week. Yeah, you improve within a week. Days.
Yeah, yeah, and then this IgG4, right? So some studies say up to 60% can persistently elevate IgG4. His is it's a little bit better, but still high. If this is autoimmune, the IgG4 remains elevated. Other studies suggest that that may increase likelihood of relapse. Would you do any other immunosuppression? I wouldn't, but I don't know if anyone else would at this point. And then the duodenal hematoma. So is this from the EGD? If this was group pancreatitis, did this increase the susceptibility for hematoma? Definitely, we know cystic changes can be seen with group pancreatitis. One study from Scandinavia found 80% have cystic changes. And then to Ilia's point, is this hematoma exacerbating his pancreatitis? And then to Sohail's point, is this all drug-induced pancreatitis? So yeah, we are very stuck with this patient. It's been 2 months and very little improvement. He's now on 1 or 2 cc's an hour of Pediatric and on a slew of pain medications.
I'm not a doctor, but we are at Mission Cure, part of the rare disease cohort that's funded by Chan Zuckerberg. And I've been surprised at how many rare diseases have manifestations in the pancreas. So I don't know. I remember you said he had Lennox-Gastaut syndrome. I don't know what else, but have you looked at whether this might just be a manifestation of the other conditions that he has?
Yeah, I mean, that's a great point. It's certainly possible. He had hypoxic ischemic injury at first. I think a lot of his complex medical history is really rooted in that rather than maybe an underlying genetic syndrome. So, did you have a question?
If time allows, that valproic acid should always be considered as a cause for pancreatitis. It causes pancreatitis in less than 1% of users, maybe around 1%. But when it does, the latency is highly variable. And often these patients, when you look at case series, have been on it for months, if not years. And because they're often neurologically impaired, it's very difficult to ascertain whether they had pancreatitis to begin with. So without knowing the trigger as a medication, but knowing that this kid took a valproic acid or is taking it, I'd highly consider talking to the neurologist about switching the medication regimen.
All right, I think that wraps up this part of the session. Thank you, Mega, for that wonderful presentation.
All for this wonderful, stimulating discussion. Please submit feedback about anything we could do different for. We do want to have a breakout next year at Pancreas Fest, specific for pediatrics, but please submit feedback of what you like to see happen and presented. And yeah, and then we have a short break, and then the next session is the award in the main room.